Hi, my name is Catrina Benson, and my community health project for Anthropology 343 is about the diagnostic journeys experienced by patients with forms of non-standard diabetes. So first of all, what is diabetes in general? We usually use the term diabetes to refer to diabetes mellitus, which is a group of illnesses impacting the body's ability to regulate glucose or sugar levels in the blood and urine. Cells in the pancreas produce the hormone insulin that allows all the cells of our body to use blood sugar. When the pancreas can't produce enough insulin, or when the body can't use the insulin that is produced correctly, the amount of sugar in the blood rises. Depending on how high blood sugar levels get, there can be both long-term and short-term effects of elevated blood sugar levels. Long-term effects of moderately elevated blood sugar can include retinopathy that can lead to blindness, kidney failure, and cardiovascular disease. Short-term effects of severely elevated blood sugar levels can cause diabetic ketoacidosis, leading to coma and even death. There are two major forms of diabetes that are commonly known. Type 1 has historically been called juvenile diabetes, although this is really a misnomer. This type of diabetes is caused by an autoimmune attack on the insulin-producing cells of the pancreas, resulting in little to no endogenous insulin production. And as a result, people with this type of diabetes require synthetic insulin, usually via shots, to survive. Type 2 diabetes happens when cells of the body become insulin resistant and the pancreas is unable to produce enough insulin to compensate. This type of diabetes is strongly associated with obesity and sedentism, and is usually thought of as a disease of lifestyle choices. Many people with type 2 diabetes will see significant improvement in their blood glucose levels with weight loss and increased exercise. There are, however, several other forms of diabetes that many people, often including general health care practitioners, are not aware of. Latent autoimmune diabetes of adulthood, LADA, is a form of slow-onset type 1 diabetes seen in adults. Although we usually think of type 1 diabetes as a disease of childhood, about 25% of the people diagnosed with autoimmune diabetes are actually adults, and autoimmune diabetes can strike at any age. Another group of diabetes forms are the monogenetic forms of diabetes called MODY, maturity onset diabetes of the young. MODY diabetes is inherited in an autosomal dominant fashion. And this is one of those genetic diseases where if you have the gene, you will have the disease, although the presentation can vary greatly from person to person. There are several forms of MODY based on a few different genetic mutations. Based on the gene involved, these forms can mimic type 1 or type 2 diabetes or have a different presentation altogether. What's important here is that the appropriate course of therapy can be different for MODY than that for either type 1 or type 2 diabetes. There's also a subgroup of people who we think truly do have type 2 diabetes, but who are thin or normal weight and active. Now, some diabetes experts argue that any patient diagnosed with type 2 diabetes who fits this mold has actually been misdiagnosed. But type 2 diabetes appears to be a spectrum, and probably there are some people who have genetically influenced insulin deficiency. Whether or not these people do truly have type 2 diabetes, they form an interesting group of patients who also have a form of diabetes that is not well known or well understood. So how is diabetes diagnosed? Well, there are three basic tests routinely used to evaluate blood sugar control. Fasting blood glucose levels, A1C, which is an indication of blood sugar levels over a 2 to 3 month period, and the oral glucose tolerance test, which measures a patient's response to ingesting a known amount of sugar. Tests available to distinguish between the different forms of diabetes include antibody testing, which when positive is a definitive confirmation of type 1 diabetes. C-peptide levels, which provides information about how much insulin the pancreas is producing, and genetic testing, which can identify the presence of genes known to cause MODY or that are risk factors for type 2 diabetes. Now here's the problem. When adults show mildly to moderately elevated blood glucose levels, they are almost inevitably diagnosed with type 2 diabetes, even if they have no known risk factors. But 10 to 15% of these people actually have type 1 LADA diabetes, 1 to 2% have MODY, and 10% are thin and do not have the standard form of type 2 diabetes. Although these patients have different types of diabetes, What they often share is a diagnostic process involving misdiagnosis. Patients who are misdiagnosed often experience significant frustration with both the diagnostic process and the medical community. They may experience delays in appropriate treatment and associated negative health impacts. They may have difficulty in getting diagnostic tests that would assist in diagnosis, and they may first find out about the existence of their type of diabetes not from medical professionals, but from the internet or other patients. Also, public awareness of non-standard forms of diabetes is low. Major diabetes advocacy organizations emphasize type 1 and type 2 diabetes, and type 2 diabetes is strongly associated with lifestyle choices. So my goal in this project was to better understand the diagnostic journeys faced by people with non-standard forms of diabetes. I put together an online survey and received responses from 16 patients with LADA or MODI. I obtained detailed descriptions of the diagnostic journeys via email and direct interview from 4 individuals either confirmed to have LADA or MODI or currently undergoing diagnosis. I also put together a survey for healthcare professionals and received responses from 1 endocrinologist and 1 certified diabetes educator. But input from healthcare professionals was generally difficult to obtain, and I focused primarily on patient experiences. This is the link to that survey if you would like to take a look at it. So what I found was that the majority of respondents were initially diagnosed with type 2 diabetes, and many were not offered differential diagnostic testing, even though their medical history warranted it. The time frame between initial blood work that showed something was wrong and correct diagnosis was generally greater than 6 months, and in several cases many years. Many patients first learned about the existence of non-standard forms of diabetes from sources other than a healthcare practitioner. Basically, they had to do their own research and ask for tests from their doctor to get a correct diagnosis. Patients almost universally express frustration with the diagnosis process and the difficulty in obtaining a correct diagnosis. So recommendations from this project: what can we do better? Type 2 diabetes should not be assumed. All patients with gross loss of blood sugar control or who do not have significant risk factors for type 2 diabetes should be tested for antibodies and C-peptide levels to rule out type 1 LADA. Established guidelines, and they do exist, for undergoing genetic testing for MODI should be consistently applied. All patients should also be informed about the existence and possibility of non-standard forms of diabetes by healthcare professionals involved in their care. They shouldn't have to go outside of the healthcare process to find out about these non-standard forms of diabetes. Also, we need to be aware that type 2 diabetes is not simply a disease of obesity. Thin type 2 diabetics require different care plans than obese sedentary patients. One-size-fits-all plans of weight loss and increased exercise may not be appropriate for all type 2 diabetes patients. Also, thin type 2 diabetics experience different emotional responses to diagnosis than their overweight or obese counterparts. They need specific support geared to their form of type 2 diabetes to allow them to achieve the best results.